Welcome back. Today we'll explore obstructive lung diseases and make sense of how they differ from restrictive patterns, how to recognize them, and how to manage them. In obstructive disease, the problem is getting air out. The airways narrow, air becomes trapped, and the residual volume rises. The lungs become hyperinflated. In restrictive disease, the problem is getting air in. Lung expansion is limited, and the total lung capacity and forced vital capacity fall. Think of obstruction as an outflow problem and restriction as an inflow problem. In obstruction, the FEV1 to FVC ratio drops below 0.7, while in restriction it stays normal or even high because both FEV1 and FVC decrease together. Now let's talk about COPD. The diagnosis is defined by an FEV1 to FVC ratio below 0.7 that does not improve significantly after using a bronchodilator. Air trapping increases the residual volume and the total lung capacity, but the rise in residual volume is greater, so the FVC ends up reduced. On chest X-ray, you'll see flattened diaphragms due to hyperinflation. COPD has two main phases. Chronic bronchitis, known as the blue bloater, presents with a productive cough for at least 3 months per year over 2 consecutive years. The airways become inflamed and lined with mucus. These patients are often overweight, cyanotic, and have rhonchi and early signs of carbon dioxide retention. The diffusion capacity remains normal because the alveolar membrane is intact. On chest X-ray, you'll see thickened bronchovascular markings. Emphysema, the pink puffer, results from destruction of the alveolar walls. These patients are thin, have reduced breath sounds, and develop hypercapnia and hypoxia later in the disease. The diffusion capacity is decreased, and chest X-ray shows hyperlucent lungs and bully. The overall management of stable COPD is similar for both types. Bronchodilators such as long-acting muscarinic antagonists and long-acting beta agonists form the backbone of therapy. Inhaled corticosteroids are added in patients with frequent exacerbations. Other options include long-term azithromycin 3 times a week, the PDE for inhibitor Roflumilast, and biologic therapy such as anti-IL-5 monoclonal antibodies for patients with eosinophilic or asthma overlap disease. Non-medical measures are essential and life-saving. Smoking cessation reduces mortality more than any other intervention. Pulmonary rehabilitation improves exercise tolerance, quality of life, and survival. Vaccination against influenza, pneumococcus, and COVID-19 is mandatory. Long-term oxygen therapy is indicated when the oxygen saturation is 88% or less at rest, and it also reduces mortality. Nocturnal non-invasive ventilation is used for patients with daytime hypercapnia. Surgical options include lung volume reduction and lung transplantation for advanced cases. During an acute COPD exacerbation, most cases are triggered by infection, usually viruses or non-typable Haemophilus influenza. About 30% are caused by non-infectious triggers such as pulmonary embolism or inhaled irritants. The cardinal symptoms are worsening shortness of breath, increased sputum volume, and increased sputum purulence. On examination, you'll find increased work of breathing, jugular venous distension during expiration, and distant heart sounds due to hyperinflation. Treatment focuses on reversing obstruction, reducing inflammation, and treating the trigger. Use inhaled bronchodilators to maximize expiratory flow. Give systemic glucocorticoids to calm airway inflammation. Add antibiotics if sputum becomes purulent with other worsening symptoms or if the patient needs hospitalization. Good empiric choices are respiratory fluoroquinolones such as levofloxacin or moxifloxacin, or third-generation cephalosporins such as ceftriaxone or cefpodoxime. Oxygen should be titrated carefully to a saturation of 88 to 92%. Too much oxygen can worsen hypercapnia. Non-invasive positive pressure ventilation is used early to unload the fatigued diaphragm, improve ventilation, and prevent intubation. In severe cases where mental status worsens, pH drops below 7.1, or ventilation fails after 2 hours of non-invasive support, intubation should be considered. Why does non-invasive ventilation help? The applied positive pressure keeps the airways open, allowing trapped air to escape, reducing hyperinflation, and restoring the diaphragm's normal curve. This decreases the work of breathing and helps clear carbon dioxide. Hypercapnia can lead to confusion and hysterexis, called carbon dioxide narcosis. When the PaCO2 exceeds 70 millimeters of mercury, patients may develop somnolence, seizures, or coma. Always check an arterial blood gas. Excess oxygen in severe COPD can worsen hypercapnia by redirecting blood flow to poorly ventilated lung regions and by displacing carbon dioxide from hemoglobin. That's why oxygen must be titrated and never given at full flow without monitoring. Remember the young or non-smoking patient with emphysema. This could be alpha-1 antitrypsin deficiency. These patients develop panicine or emphysema in the lower lobes and may also have liver disease. Diagnosis is by measuring serum alpha-1 antitrypsin levels. Treatment includes intravenous supplementation and standard COPD medications. Next, let's distinguish asthma from COPD. Asthma is reversible, COPD is not. In asthma, the diffusion capacity is normal or even increased. In COPD, it's normal or decreased, and in late stages it's clearly reduced. Asthma is driven by inflammation and bronchoconstriction, so treatment targets both with an inhaled corticosteroid and a beta agonist. COPD involves mucus hypersecretion and tissue destruction, so long-acting muscarinic antagonists are key. Common asthma medications include short-acting beta-2 agonists such as albuterol, long-acting beta agonists like salmeterol, inhaled corticosteroids such as beclomethasone, oral prednisone for exacerbations, antimuscarinic agents like ipratropium, and leukotriene inhibitors like montelukast or Zilliton. Persistent asthma is diagnosed when symptoms occur most days, when there are nighttime awakenings, or when the FEV1 is reduced despite bronchodilator use. These patients should be treated with a scheduled inhaled corticosteroid plus a long-acting beta agonist such as formoterol. If symptoms persist, increase the steroid dose and add a long-acting antimuscarinic such as tiotropium. During an acute asthma exacerbation, there's an immediate phase caused by histamine and leukotrienes that produces bronchospasm and mucus, and a late phase driven by cytokines that maintains inflammation. Treatment in the emergency setting includes repeated inhaled albuterol, adding ipratropium for moderate or severe attacks, and giving systemic corticosteroids such as prednisone or methylprednisolone. Intravenous magnesium can be used for severe bronchospasm. A chest X-ray is only needed if the presentation is atypical. Watch for warning signs of impending respiratory failure, a respiratory rate above 30, oxygen saturation below 90%, accessory muscle use, confusion, a silent chest, and a normal or high carbon dioxide level when it should be low. These are red flags for respiratory muscle fatigue and the need for ventilatory support. Inhaled steroids can cause hoarseness and oral thrush, so rinse the mouth after use. Systemic steroids cause transient leukocytosis with a neutrophil predominance. High doses of beta agonists may cause low potassium, muscle weakness, and tremor. Theophylline toxicity causes tremor, seizures, vomiting, and dangerous arrhythmias, especially when combined with ciprofloxacin or in elderly patients. Asthma has several special forms. Exercise-induced bronchoconstriction presents with wheezing and shortness of breath 5 to 10 minutes after exercise. It improves with pre-exercise inhaled therapy. Aspirin-exacerbated respiratory disease combines asthma, nasal polyps, and NSAID sensitivity. Treatment is avoidance of NSAIDs and the use of leukotriene inhibitors or desensitization if necessary. Occupational asthma develops from sensitization to antigens such as animal proteins, flour dust, or chemical fumes. Symptoms worsen at work and improve on weekends. The diagnosis is confirmed by a fall in peak expiratory flow of 20% or more at the workplace. Asthma may worsen during pregnancy due to hormonal and immune changes, especially in the second trimester. The same medications are safe and recommended, with careful monitoring. In sickle cell disease, recurrent lung injury can cause airway hyperreactivity that mimics asthma and should be treated similarly. Now, let's address a few important mimics. Heart failure can look like COPD with dyspnea and wheezing, but patients have crackles, an S3 sound, and elevated BNP levels. Mucus plugging in asthma can cause atelectasis, leading to collapse of part of the lung, tracheal shift toward the affected side, dullness to percussion, and opacity on chest X-ray. Fixed airway obstruction, such as tracheal stenosis from prolonged intubation, causes both inspiratory and expiratory flow limitation and biphasic stridor. Paradoxical vocal fold motion, also called vocal cord dysfunction, causes inspiratory stridor and throat tightness, often triggered by exercise or stress, especially in young women. During attacks, encouraging the patient to sniff or pant helps reopen the cords, and speech therapy prevents recurrence. Finally, pulmonary rehabilitation and long-term oxygen therapy. Rehabilitation includes supervised exercise, breathing training, education about inhaler technique and early recognition of exacerbations, nutritional counseling, and psychological support. It reduces symptoms, hospitalizations, and mortality. Long-term oxygen therapy improves survival in COPD with resting oxygen saturation of 88% or less, or slightly higher if there is COR pulmonal or secondary polycythemia. The goal is to maintain oxygen saturation between 90 and 94% throughout the day and night. In summary, obstructive disease means air cannot get out, and restrictive disease means air cannot get in. COPD diagnosis is based on a reduced FEV1 to FVC ratio below 0.7 that does not reverse. Chronic bronchitis keeps the diffusion capacity normal, emphysema lowers it. Smoking cessation, vaccination, rehabilitation, and properly indicated oxygen therapy save lives. Asthma is reversible and inflammatory. COPD is fixed and destructive. And remember the special cases: alpha, 1 antitrypsin deficiency, obesity hypoventilation, aspirin-sensitive asthma, occupational triggers, and vocal cord dysfunction. That wraps up obstructive lung disease. Next time we'll explore restrictive patterns and interstitial lung disease. Breathe easy and study smart.